you can let us know. So you're all welcome. My name is Sarah, and then I'll be taking the session for tonight. Yes, I hope that we'll be able to, all grasp something before we leave here. So just relax, enjoy the session. If you have questions, you can let them come in, comments, suggestions, any further information you think you have that we could make do with it or we could use, you can let it come in. Great. So our topic for today is hypertension in pregnancy. Yeah, so we are only going to limit it to hypertension in pregnancy and not all of or the general hypertensions that we know, though it's not quite so different. Yeah. So we'll be talking about what hypertension is, what it is in pregnancy actually, the classifications of hypertension in pregnancy. We'll talk of the causes, we'll see a few management and then some prevention tips for it. Yeah, to help us out. Great. So I'll be using terms like protein in urea or proteinuria. It simply means protein in urine. I'll use terms like HPT. So you may see HPT. It simply means hypertension. It's just a short form for hypertension. SBP is systolic blood pressure. That is, and then DBP is diastolic blood pressure. You see, when we record the blood pressures, we write a top figure and then a down figure. So the top is the systolic and then the down is the diastolic. The systolic is reading your heart when it's pumping, and then diastolic is reading your heart when it's relaxed, after it's pumped and it's relaxed. I hope you get the difference, yes. So you see mmHg, that's millimeters per mercury. That's just the units for hypertension. Great. And then you see BP. BP is everywhere, blood pressure. And then gestation simply means pregnancy. Is the same thing as sciences. Great. So basically that is what we have for the terms that we'll be using. So in general, what is hypertension? So hypertension is defined as a blood pressure of 140/90 millimeters per mercury or greater. Yeah, so if you are pregnant and then you start, or in general, if you have you check your blood pressure and then you see 140/90 or higher, then we say that, well, you are at risk of having hypertension. It can also be defined as a rise in the systolic blood pressure 15 millimeters per mercury greater than your baseline. So it means that everybody has a baseline. The first time you checked your blood pressure is your baseline values, okay? Or for some weeks before the new, that is your baseline values. So if your baseline, you happen to check and then it goes higher, 15 millimeters per mercury greater than the previous baselines, then it means that you can be classified as having risk of having hypertension. Again, we should note that there's also an elevation, and this elevation must be present on two different occasions. That's 4 to 6 hours apart. So we just can't say that because your baseline values were okay, but then when you came, your systolic blood pressure is 15 millimeters greater, so you have hypertension. No, it should be on two different occasions, and then it should even be checked more than twice with an hour of 4 to 6 hours apart. So if you come into the facility, your baseline values were okay, you come in this time, we see a rise, we would have to check on another occasion again, and then after checking, we'll have to even let you wait for like 4, 5, 6 hours. We check again, and then if it's still the same, then we can classify you as having or developing hypertension. So hypertension in pregnancy itself is defined as a systolic blood pressure of 140 millimeters per mercury or higher with a diastolic blood pressure of 90 millimeters per mercury or higher. Again, a rise in the systolic blood pressure of 30 millimeters per mercury or higher during pregnancy, with a rise in the diastolic blood pressure of 16 millimeters per mercury or higher during pregnancy. So this is the definition for hypertension in pregnancy. I hope you are not confused. So the previous one was for the general kind of hypertension. Now this one is limited pregnancy, and we said that for pregnancy it's still 140/90 or higher. That is hypertension. That is when we start seeing these values, we could classify you as having hypertension. Now again, we said that if there's a rise in the systolic blood pressure by 30 from your base values, baseline values, and then the diastolic, there's a rise 16 millimeters per mercury during pregnancy, then we can say that you're having hypertension. Now, it should be noted that both the systolic blood pressure and then the diastolic blood pressure all fall during the second trimester of pregnancy, and then they rise slowly again towards term. That is a normal physiology. That is something that happens on a normal note, and we should take note of. Okay, and then hypertension may also be associated with proteins in urea or proteinuria, or proteins in urine, and that is what gives us a special condition called the preeclampsia. We'll get there. So in pregnancy, we have classifications for the hypertension itself. Okay, and the classification depends on when the hypertension started, either before or after 20 weeks of gestation, and then it's persisting 6 weeks after delivery. Okay, so the classifications, we have pregnancy-induced hypertension, that is PIH. We have under PIH is also the same as gestational hypertension. That is solely due to the pregnancy. Okay, and then we have that is pregnancy induced. So the pregnancy is inducing the hypertension. That is why it's called gestational hypertension or PIH. And then we have the preeclampsia. And preeclampsia is also known as proteinuria hypertension. And I said proteinuria is what? Protein in urine. Great, so that is it. And that is what gives us the condition that I was saying, that hypertension can also be associated to proteins in urine. That gives us eclampsia or preeclampsia as a condition. Then we have chronic hypertension. Again, we also have chronic hypertension with or superimposed preeclampsia or eclampsia. And then we have unclassified hypertension or unclassified protein in urea hypertension. I'll explain all of these, so let your heart be at peace. Okay. Great. So the PIH or the gestational hypertension, that the pregnancy-induced hypertension, occurs normally after 20 weeks of pregnancy and is often diagnosed after when the mother even rests, or after resting, the woman's blood pressure rises above 140/90 millimeters per mercury on at least 2 different occasions. There's no protein in urea in gestational hypertension. It's just the hypertension. It's just the BP's rising. That's all. And it occurs after 20 weeks. After 20 weeks of gestation or of pregnancy. Note that hypertension diagnosed for the first time in pregnancy, which does not resolve during postpartum, is also classified as gestational hypertension. So let's say you do not have hypertension before pregnancy. Now, because of the pregnancy, you got hypertension. You developed hypertension. Now, after pregnancy, we are expecting that PIH will vanish on its own. Okay, but then if it doesn't, then we can also still classify it as pregnancy-induced hypertension or gestational hypertension because you got it out of the pregnancy. It's quite unfortunate that some of us may have to develop conditions for life because of pregnancy. It's quite something else. However, I think we can still take care of ourselves very well with these preventive tips and management tips that we'll be learning today. So we have the PIH, the preeclampsia. That's a pregnancy-induced hypertension, but still preeclampsia. And then this condition is specific to pregnancy, like I said. It's the development of hypertension. So this time, we are seeing that the mother's BPs are rising above 140 millimeters per mercury onwards. But it's not just the hypertension, okay? It's also with proteins in urine and then swelling of the face, the hands, and the feet. That is edema. So it is a condition specific to pregnancy, and then it is the development of hypertension with proteins in urea or edema, or both of them after 20 weeks of gestation. I hope you get the difference. I said with gestational hypertension, it is just the hypertension or the BP's rising after 20 weeks of gestation. No proteins in urea, no edema. But with preeclampsia, this time we are having the BP's rising again, we are having edema, swelling of face, hands and feet, and then we are having proteins in the urine. I hope you get me. Great. So mostly on your visits, on your antenatal visits to the clinic, you will have the midwife or the nurse put a dipstick or a reagent strip, and then it's used to check in your urine. She'll ask you to go and urinate and come. She dips a dipstick into it or a reagent strip into it to check the grade of the proteins in the urine. So the grade of the proteins depends on us entirely. It comes, we have trace, we have 1+, we have 2+, 3+, and 4+. Okay. So, and then we use a color change. So you see colors on it. That is what is able to tell us the grade of the proteins in urine. Yeah. So normally, if you have an early morning urine in still a sterile bottle that still contains protein in urine, and the BP may be high, maybe the urine may be out of contamination, so you'll be asked to do a further test. Either you do a high vaginal swab, HVS, or you go to the lab to do further testing for us to see what is actually causing it. So even with the preeclampsia, we have different classifications for the preeclampsia. We have the mild, the severe, and then the imminent preeclampsia. Okay, so the mild preeclampsia, it is the signs and symptoms that you present. What you are presenting is what we are using to classify whether it is mild, severe, or imminent, okay, or fulminant. Now, with a mild preeclampsia, we have edema of the, so we'll see edema of the feet, just the feet, and then a part of the ankles, and then the pretibial regions. And then you realize that the diastolic pressure will normally be between 90 to 109 millimeters per mercury, and then the systolic blood pressure will be between 140 to 150 millimeters per mercury. And then the proteins in urea mostly around that time is just 1 to 2+. Yeah, that is the mild case. In the severe preeclampsia, you realize that the edema is mostly variable. It's either you're having edema of the face or the hands or the feet, and then the proteins in urine present maybe 3+ or greater. And then, but that is in the absence of urinary tract infection. Okay. And then there is marked rise or a sharp rise in just the systolic and diastolic pressure. So normally the systolic pressure is around 160 millimeters per mercury on 2 different occasions, and then the diastolic pressure will also be around 110 to 120 millimeters per mercury. And then the fulminant eclampsia, or the severest, that's the imminent eclampsia. That one, it is getting into a serious stage. The signs are serious, and then they need to be a watch out. Okay, they are danger signs of the onset of eclampsia itself. With that one, you realize that we have a sharp rise in temperature, marked increase in edema. It means that edema, when we pit your skin, edema is when we pit your skin, it's supposed to rise. Okay, when we pit, it's supposed to rise. But this time, when we pit in, it doesn't rise again. It's still in. There's a sharp increase in edema everywhere. Your face, your hands, your feet, everywhere is swollen, such that when we pit, your skin does not rise or bounce back again. You have visual disturbances, blurred vision, flashes of light in front of your eyes. You'll be vomiting. You'll be having epigastric pain due to distension of some of the organs like the liver, and then you'll be having increased protein in urine. Sometimes we could not even grade it, because we could grade it above 4 and the colors are so something else. And then we'll be having severe frontal headaches, for the imminent eclampsia. So you realize that it's really not a pleasant stage to get to. And then we will also expect that the woman will be able to urinate for us. But however, we will be seeing signs like she's not able to even produce urine. Okay, there's marked increase in urine diminishing. Urine output diminishes. Okay, less than 400 mils in 24 hours. She cannot even give us 400 mils, 300 mils of urine. There's drowsiness, there's increased hypertension. I mean, it's actually very severe. Yeah. So that is that for eclampsia. That is that for pre-eclampsia. Pregnancy-induced hypertension, that's gestational hypertension, we've spoken about it. and then we are done with eclampsia itself. Now we have chronic hypertension, and chronic hypertension as another classification of hypertension. With this one, the person was hypertensive before becoming pregnant. That is when we can say someone was a is having chronic hypertension. So it's not because of the pregnancy. You already have the hypertension before becoming pregnant. And then with this, we always see that there's a rise. So it means we don't have to even wait for 20 weeks to be able to tell that you're chronic hypertension, because you're already having it before pregnancy sets in. Agreed. So there's always a rise in the blood pressure greater than even before the 20th week, and it's always persistent even after delivery. For about 6 weeks after delivery, the hypertension is there, and that's why some of you may be kept in the hospital for some time after delivery. And then in chronic hypertension, there may not be protein in urea. There may or may not be, because the moment we see proteins in urea, it means we are going into preeclampsia. Okay, so it means that you'll be a chronic hypertensive superimposed with preeclampsia, and that wouldn't be an easy thing to manage at all or be in at all. So normally in the first half of the pregnancy, we don't see the proteins in urea. It's when it's ongoing, when the mother is not able to care for herself, that we see those things. Sorry. So we have chronic hypertension superimposed with preeclampsia or eclampsia, and I think I've explained this just now in the previous slide. So I said that is when someone is a chronic hypertensive, that is having the hypertension before pregnancy, and then we see protein in urine in the second half of the pregnancy. That is when we see that you are a chronic hypertensive, and then now preeclampsia wants to attach. And we said preeclampsia is hypertension with proteins in urea and then edema. So I hope you understand the classification of hypertension now. We have an idea. So by now, those of us who are a bit hypertensive, we should know which class we fall in, just so you wouldn't, I'm doing this just so people wouldn't be having issues running helter-skelter, worrying so much about, sometimes you are just having hypertension, sometimes you are just having a mild preeclampsia, okay, sometimes you are having a severe but not imminent. So I'm just doing this for us to be able to tell our classifications, and then some of us will help some of us to also be at peace with ourselves and not panic so much as to what hypertensive condition we are going through during this pregnancy or during the pregnancy. So the unclassified hypertension, that one we don't even know where to put it. It can be with proteins in urine or not, okay? And that one, the woman never had hypertension, and after 20 weeks, we couldn't even see anything. But however, all of a sudden, for the first time in the second half of the pregnancy, we are seeing that the woman is having hypertension, and we don't know where it actually started because she's actually never experienced it, not in any pregnancy anywhere. So that will be an unclassified. We can't say it's because it's PIH. Yes, it's PIH, but we cannot classify it as solely under PIH. It's just occurring. So that will need further checks, okay? And though normally those ones, they resolve later on their own, okay? When the plasma uric levels, they go down, that is it. After delivery, the BP will resolve. However, if it does not resolve, then it means that the woman will be moving into a PIH, a chronic one, okay? A gestational hypertension, which is a chronic one. But the majority of unclassified hypertensions, where once in a while we just see the woman's BP rise, that one is resolved on its own right after the pregnancy. Simply means that there's the tendency of the pregnancy inducing the hypertension. However, it is not established. So it's nothing to really worry about. You just need to manage yourself with the preventive tips, and then you would be fine. So what are the causes of hypertension in pregnancy? The causes of hypertension in pregnancy. Normally, there's not so much specific cause. However, we could say that having a history of hypertension, let me say there's a history. Your previous pregnancy, you had hypertension, then there's always a chance that history has a chance of repeating itself. So it means that hypertension could occur again in the pregnancy. All right, I hope you get it. History always has a chance of repeating itself. So if you've been hypertensive before, or maybe there's hypertension somewhere in the family, which I'll come to the next point, that is hereditary, then you are likely to, you are predisposed. They are just predisposing factors, risk factors. We are not saying that if you've had hypertension before, then it means that you are going to get hypertension again in the pregnancy. We are only saying that it is a predisposing factor. The one who's developed hypertension in pregnancy before is at a higher risk of developing it again in another pregnancy than whoever hasn't even developed it before. Okay, that doesn't mean if you haven't developed it before, you wouldn't develop it before or again or ever. Just that we are saying that history has a higher chance of repeating itself. That's why we have to take precautions. Okay, and then hereditary factors, in the cases where you have hypertension running in our families, then we know that you are at risk of developing hypertension because genetics. This is where genetics comes to play. That's why we take your histories, and we ask you, has any family member have had hypertension before, especially your first line family members, mother, father, grandparents, then it's likely that you may develop hypertension. Then again, obesity comes from almost a lot of inactiveness. Obesity predisposes us to other conditions like diabetes and pregnancy, which we saw the last time, and we said diabetes and hypertension, they are cousins. So one who is obese normally has a lot of fat cells, and fat cells are insulin resistant, and these insulins puts us as a higher chance of developing diabetes. And the higher you are developing diabetes, the higher you are developing hypertension. They are cousins. So then again, that is how it is. Then we have emotional stress. Now, the one who always stresses herself emotionally has the chance of getting hypertension a lot. So during the pregnancy, I'm going to plead with our supportive persons at home with us. Could be our husbands, our parents, whoever is with us at home. Please talk to us. Take us out, give us praise. Pregnancy itself is already a stress on its own. We do not need it to you to have a lot of emotions. Then again, there's still a chance of developing emotional stress during pregnancy because of hormonal fluctuations and tendencies. So at every point in time, you would need to talk to someone. You need to come for care because the weight is a lot and you cannot carry it alone. Now, emotional stress causes spasms of the blood vessels. Spasm simply means breakages in the blood vessels. So it means even blood flow is impeded, meaning we are not getting the right streak or flow of blood to the heart, and it poses a lot of stress on the heart's ability to function, and that is where we will be at risk of developing hypertension in pregnancy. So let's take note of that. Great. So we also have smoking and alcohol intake. Those are generally not healthy things. I think we saw that during drug and substance abuse and what they have a tendency of crossing the placenta, and then these things contain a lot of nicotine, and then nicotine will also again cause spasms to the blood vessels and what have you. So it's generally not healthy. Pregnancy and smoking and alcohol is a no, not even wine. And then we have the young mothers, and then elderly mothers. Now, I think I explained the last time that normally the hearts we assume that when you're extremely young, you're a teenager, the organs ability to be strong, the organ hasn't really developed so well, so its ability to function is a bit low. So at that stage, we are putting more pressure on the heart to pump more because pregnancy demands a blood increase, and if your organ is not really that developed, you are going to have problems. Again, we said that if you are extremely elderly too, the organ in a way has become a bit weak, and so it means that there's going to be functionality problems, and that may also be a cause that it may also predispose you to having hypertension in pregnancy. Then we have a condition of the placenta called hydatidiform mole. Yeah, it's a malformation of the trophoblastic cells of the placenta. You don't need to worry yourself about these big words, okay? Yeah, it simply means that there's a proliferation, increased growth of the placenta. So it makes it look like it's rather a fetus that is growing, but no, it's rather the placenta that is overgrowing, and it even grows into a lot of cells in the uterus. So it causes a false pregnancy in there, and this has a whole, and because it has a tendency of just growing and growing, it causes the heart will also need to pump work because to meet up, and that is what predisposes us as having the hypertension, because it grows at a faster rate, and the woman may even have a lot of signs of pregnancy as though she's pregnant for real. However, it's just the trophoblastic cells of the placenta that is just growing. Sometimes you see the fetus a little bit developed, but not at all. With that, the woman will have to undergo a procedure to get all the moles out, and then mother will be fine. Then we have multiple pregnancy. Now we are not saying that if you have twins, you are pregnant with one or two or more fetuses in there, it means that you are going to get hypertension in pregnancy. We are only saying that it simply means that the heart will have to pump more workload. It simply means more workload for the heart to act. Yeah, more workload. If the heart is going to pump a little number of blood for just one fetus, because we are 2 or 3 or 4, you have to pump to meet up. You have to overwork, and that is what is going to cause the mother being predisposed to hypertension. We have polyhydramnios, where there's excessive amniotic fluid, excess of it. So the least chance, we have to work to meet up to that. Our organ must work to meet up to that, and that is what. And then I've already explained medical disorders like the kidney problems, diabetic problems also predisposes us at getting hypertension in pregnancy. Great. We'll soon be done, don't worry. So let's take a look at how we manage hypertension in pregnancy in the facility. Sorry once again. I'm actually not so so kindly forgive me for that. Yeah. So do not panic. I put this as part of the lesson just to make sure that most of us wouldn't think that there's no management for hypertension in pregnancy. So if you're experiencing something like this, you are all alone. No, you are not all alone. There's actually a lot of management for hypertension in pregnancy, and that is why you have to look out for the danger signs in pregnancy, which I spoke about. I spoke about excessive headaches, excessive high body temperatures, bleeding, abdominal cramps, excessive, anything you experience in the excessive from the dizziness, just walk into the facility. Let's get you checked up. That's why I spoke about going on for your antenatal visits and what have you. Now the moment you do these things, we'll be able to notice these conditions early, take you through some management before it gets to even imminent stage. So it means that if you are able to keep up with your doctor's appointments, you should never worry about hypertension in pregnancy having its toll on you, unless you were chronic hypertensive, which in actual sense we still have management for you, strict monitoring up until you deliver. Yes, so the main point is, if you know someone who is having hypertension, experiencing signs and symptoms of hypertension in pregnancy, which you have known, you have seen it, the headaches, the blood visions, and what have you, encourage the person to go to the facility for care. So in mild cases, normally we advise strict bed rest. And I'm putting this here just so that when you go to the facility and your doctor says, I'm admitting you for some days, you have to rest, you have to do this. Comply. Okay, we need you. We need you alive as much as we need baby alive. Just so you would be able to know that, okay, this is what is involved in the management of hypertension in pregnancy. Just comply. Then we get you safe, we get baby safe. And at the end of the day, we all at peace. So we have strict bed rest. And then normally we nurse you in a semi-prone position, more like the Fowler's position. Then we check your blood pressure every 4 hours. So just to comply, just for us to know that, yeah, there's progress. Then we always do daily weight check, because like I said, diabetes and then hypertension are cousins. There's definitely the moments where we are going to have issues. Yes, so we have to check our weights daily, and it will be done for you even whilst you're on admission, just to make sure that your weight is okay, and then we are not sipping into the diabetic stages. Then we'll do laboratory investigations. We'll check the urine. Even after the dipsticks, we'll do further tests at the lab. Okay, we do electrolysis, FBCs, your uric levels, and whatever. You don't need to worry about these things. You just need to comply to them. We use medications such as nifedipine, hydralazine tablets, methodopa, all other medications, hypertensive medications related, Nefecad, labetalol, amlodipines, and what have you. Yes, all those are to help with the hypertension management. Then for fetal monitoring too, we monitor the fetus very well. So aside you, we think of fetus too. So we do fetal monitoring. That's why we have the scans, then the fetal cake charts. So the midwife or the doctor may give you fetal cake charts too. Be doing it, check the activity of the baby. We put some of you on CTGs from 35 weeks, 36 weeks, 37 weeks. It depends. Normally, CTGs for a normal patient starts from 37 weeks. However, if we realize that you have conditions that are of much concern, then we start earlier, like 35 weeks, 36 weeks, yes, even 34 weeks, yes. It should depend on what you present it with. So if you're having a normal presentation, there's no need starting a CTG for you before that. Okay, so we do all those things. Okay, and then the fetal cake count shouldn't be less than 10 in a day, in 24 hours. Okay, then patient is normally delivered around, we monitor you, and then you get delivered around 38 to 40 weeks, and it should not go, your pregnancy should not go beyond 38 40 weeks. In severe cases, we nurse you, we admit you into a single dark room. Even on a firm mattress, sometimes we put side rails. If there's no side rails on the floor, we administer oxygen, suction apparatus, we give receivers for vomiting, we give padded spoons into the mouth, we give sedatives to keep the patient relaxed. The patient is never left alone. We do lab investigations, IV fluids to resuscitate, blood samples, fetal monitoring again, then fetal heart rate and auscultations. So how do we prevent hypertension? We do early antenatal attendance. I've already mentioned that. Then you need to modify your lifestyle. Means you need to exercise so that we check your weight management, your diet, because we do not want you to develop the other condition. Enough rest, avoid smoking. Then you have to adhere to the medications that we give you. Some of you take it today, no, all those things, you stop taking it by the time you realize you are relapsing. Then you avoid emotional stress. So get support. If there's something weighing you down, talk to us. Get someone, talk to the person, go for counseling, have an idea of your blood pressures every time. That's why we check them every time. And then stay hydrated. I believe with these things you should be fine. So thank you so much for joining in for the lesson on hypertension. I hope you are now well informed, and then you are not going to have a lot of misconceptions and what to do. Again, note danger signs and come to the facility for care. Thank you.